Welcome to the Auburn Medical Group YouTube live stream, the entertaining medical live stream where viewers can ask real-time questions of real medical doctors. And here are our hosts, Dr. Mark Vaughn and Dr. Gwen Vaughn.
Hello and welcome to the Auburn Medical Group live stream on YouTube with Dr. Mark Vaughn and
I'm Dr. Gwen Vaughn. You made it. Welcome.
You did and we did. And we have people who are going to be in our audience. Jennifer, I do have the comments set up so you can find those somewhere.
Jennifer has joined us.
Yeah, Jennifer's here. It's the green thing down here somewhere. So
Don't
your
mind.
comments will be used on the show if you're watching live here today on March 13th as we're talking about
Mammograms.
mammograms because the
in the news.
The announcement the FDA put out late last week has been a letdown, to put it in breast terms. So,
I see what you did there.
yep. Yeah, letdown. Jennifer, you can laugh out loud. It's okay. You don't have to.
Yeah.
Okay. Oh, and we do have a live chat actually going, so that's good to see. I see Lindsay's out there. Thank you, Lindsay. You guys need to know who Lindsay is because she's a big part of the show behind the scenes and fueling us with Dutch Brothers along with some other helpers.
I am fueled and ready to go.
Okay,
Yeah.
This announcement came out late last week. I believe it was the 9th. And let's see. Let's jump to some things here. It was not unique for a lot of states.
Sure.
A lot of states already have this requirement that is for whoever's taking a mammogram to notify the patient if they have a radiologically dense breast. So this is a radiologic term.
Right. Mm-hmm. Something they
Radiologist
see on
looks at the mammogram, and mammograms are black and white. So air or surrounding the breast is just absolute black, and then super dense breast tissue is white.
Mm-hmm.
Cancers typically are white,
Right.
or the whitish end of a gray scale.
Yeah.
And the radiologists say, hey, how am I supposed to see a cancer in the middle of all of this dense breast tissue? Hard to resolve.
That is, yes. So,
Right?
Yeah, it makes sense.
You up to speed?
You're trying to find what they say is, a whiteout. You're trying to find, something in a whiteout. Can be difficult to find.
Okay. So let's actually take a portion of their statement.
So it
There's a
kinda
link
makes
to it in the
sense.
description. Jennifer, on the
At
slides,
face
can you
value.
give us our last slide? And we'll read a portion of it, and we'll talk about it for a little bit. So we'll get back to these. I put them in out of order. Here's the FDA statement. Jennifer, I can't read that. Can you read that for us?
I can read it.
Approximately half of women over the age of 40 in the U.S. have dense breast tissue. A description of its appearance on a mammogram. Dense breast tissue can make cancers more difficult to detect on a mammogram. Additionally, dense breasts have been identified as a risk factor for developing breast cancer. The amendments finalized today provide specific language explaining how breast density can influence the accuracy of a mammogram. Let's see. They recommend patients with dense breasts talk to their healthcare provider about breast density, risks for breast cancer, and their individual situations.
Okay. So this is our time to go ahead and switch it.
Okay.
This is our time to talk about it now. There's a number of things in that. I should have broken that down a little bit because there's a lot in it.
Right.
So I think the first thing that jumps out at me is what it is. They say it's a radiologic term.
Mm-hmm.
And I did a little bit of research, and I didn't include any of the references in today's presentation, but this determination of how dense it is actually subjective. I could not find that they have an objective way, like a densitometer looks at DEXA scans.
Yeah.
Those of you who are familiar with DEXA scans or these scans that look at bone density, they actually have a scoring system for that. There is a scoring system for breast radiologic density, but it's not done by computer that I
Purely
could
subjective,
find.
yeah. I believe it's
so
just the call of the radiologist.
I actually did find studies that show that they disagree quite often on how dense it is. And so for a breast to fall, I think it's a category of, I think there's 5 levels of density.
Yeah.
And I think it's the last 2 or 3 that
I
count
thought it was
as
the last
dense.
2. I didn't know that.
Last
But
2,
anyway,
okay.
yeah.
Like 4 and 5 levels 4 and 5, for example. I'm not saying that for sure because I don't know exactly that level of detail on this. So they're saying if this radiologist thinks you're a 4 and not a 3, then you're in the group of nearly half. It's like
Dense
44% of women that we're going to say have dense breasts. Note, they get less dense as you get older,
right?
Radiographically. So something that's an issue now when you start getting your mammogram at, say, age 40 if you're high risk or age 50 if you're not, may not be an issue the next time you come in for a mammogram.
Right.
But is it really an issue?
That's the question. Maybe we should start with the official recommendations. Well, are there official recommendations? Maybe that was the recommendations we follow, and then how would this change that? Maybe that's how we should approach this.
So the official recommendation, which was brought about by the United States Preventive Services Task Force, USPSTF. Can you tell? Is it picking up the difference between an F and an S? There's a difference. United States Preventive Services Task Force, a part of the NIH, they look at all the studies. This is a body of experts in the field that look at it, and they look at individual studies. They look at
meta-analyses.
Where they get a whole bunch of studies together and look at them in a group and then publish the results of that, like a Cochrane review.
Right.
There's some other ones. And then they decide, okay, what should we do for recommending? And they say, you know what? Mammograms save lives. Mammograms detect breast cancer earlier than about any other way, earlier than people even feel them themselves, and certainly earlier than doctors are catching it any other way other than mammogram. So that's a good thing. And we've shown that it can reduce mortality or deaths by having people get these mammograms and discover these cancers. And we've avoided, over the years we've had mammograms, I don't know how long it's been a standard, decades, with an S, decades. That's a joke from earlier today. We have indeed found that breast cancers are being discovered that otherwise would kill people, according to studies of large groups of women specifically. We don't have any standards for getting mammograms for screening in men because they don't get breast cancer that often. So we have these standards, and they used to be every year, and it used to be starting really young.
Yeah.
Really young with these more dense breasts. And what happened?
It showed that it just doesn't prevent as many deaths if we lengthen that out.
Yeah.
Now, so it's every 2 years. So the official recommendations are age 40 to 49. Have a discussion with your doctor based on your risk. That is the official recommendation, like family history. That's probably your biggest one. Yeah. And then not dense breast tissue. That's not one of those that you're supposed to have a discussion about. But now the FDA says.
Did you hear the reading on that?
That's what the FDA says, not the USPSTF, which we'll come back to. And then from 50 to age 79, every 2 years, get your mammogram. That is the official recommendation. Grade B recommendation, which is a very good one. So that's A is like absolutely do this. B is like next best and still recommended. And then age 80 and above. Yeah, 80 and above. 79 and above, I think it's actually, but
I thought it was 75.
Oh wait, you are right, 75. I was like, it's 70 something. It's not 80 because 80 is not. Yeah, that's something else. So 75 and above, you should talk with your doctor, but really the studies don't show that it's helpful. That's a rated I, as in inconclusive. We don't know for sure. Yeah. And actually, the USPSTF makes a recommendation about dense breast tissue. So maybe we should talk about that. They recommended.
Okay. Yeah, let's talk about that. So, Jennifer, can you actually give us the 2009 slide?
Yes.
So there's a slide that we have here of a statement that came in 2009. They actually published it in the Annals of Internal Medicine, where they said, can you read it?
It says USPSTF concludes that the current evidence is insufficient to assess the balance of benefits and harms of adjunctive screening for breast cancer using breast ultrasonography, MRI, DBT, and other methods.
So in 2009...
Insufficient.
Insufficient evidence. So...
Well, from then, we obviously have better evidence now, right?
So then let's jump to 2016.
Which is the...
Can you read that one?
Yeah.
Same body made a statement.
Updating their statement.
They wanted to make an update.
With all the new studies out there. And This one says whether cancers identified by supplemental screening have better outcomes and how many of them represent cancers that would not otherwise be clinically apparent cannot be determined by the studies published to date. So from 2009 to 2016, we did not have any change in that recommendation. It was still an I, and that is the current recommendation by the USPSTF, which is a different body than the FDA.
And so this body in the NIH that we get all of our recommendations from seems to be differing from the FDA with this thing requiring whoever's doing the ultrasounds to tell the patient they have dense breasts and you need to go talk to your doctor about it.
And what would you do?
Yeah.
I mean, that's the question. How do we change that? Okay, every year mammogram, every 6 months mammogram. What does that mean that you have these breast mammograms? And then you've got to consider radiation exposure.
Well, it looks like they're not recommending mammogram.
They're going to ultrasound.
Doing something else.
Because mammograms is not as
zero evidence
beyond mammogram.
When looking at studies to try to see, did it make a difference? Did we save any patient lives? And there was that one word in there, overdiagnosis in parentheses. Did you see that?
Yes.
We should talk about that.
Yeah, that's something to consider.
So cancers that would not otherwise be clinically apparent. So if I have a cancer in my body, I go through the rest of my life with nothing ever happening because of that cancer. Even if it spread to another place. If we didn't know it until after I'm dead, they do an autopsy and say, hey, you know what? He had cancer.
He had cancer.
It didn't kill him, nor did it cause any effect on his health, but it was there.
Yeah.
Should we know about that?
I would argue no.
Why?
Because actually knowing about it may cause you to get a treatment that has its risks and possible outcomes that are undesirable.
Treatment or test or procedure.
Yeah.
So there's a lot of things that could, or the anxiety from it.
Sure.
Oh, is this something?
Even that.
If it never did anything. So we don't know. Overdiagnosis is a term of kind of an unknown.
Yeah.
We don't know. We don't know every type of breast cancer, what would happen. There's different types. What would happen if we just left it alone and didn't take it out? Because who would volunteer to be in that study if you're possibly in the group that, oh, let's just keep the cancer in you and find out what happens. But you would want to be in that group if we could find no evidence at all that doing something made a difference. And that's where we are. We don't know what difference we can't document that it's saving lives, like getting regular mammograms does.
For these, this
additional
imaging. We are not saying that mammograms are not saving
we love
it. Yes.
We love mammograms according to the USPSTF recommendations. We love that.
Which even that differs from some other organizations out there, especially organizations who really want you to get your mammogram because it gets them more money.
Because that's their bread and butter, reading mammograms. So of course they say to get them every year. And of course the report, when they give it to you, is going to say, talk to your doctor about your dense breasts, 50% of you.
Or they send out that 1 year follow-up on the completely normal mammogram saying, hey, it's time to get your mammogram.
For your mammogram. It's only been a year.
Is it?
So, come in, let us irradiate you and maybe find something that isn't going to make a difference in your health, which would have to be biopsied.
Right.
Or possibly a needle biopsy by an interventional.
Where are we going? It's radiologist?
Radiologist.
In the same...
Who's the guy who... Yeah.
So, in the same field, making the same...
Yeah.
Well, making a little extra money.
So we really do... This FDA statement is saying a completely different message about breast density than the USPSTF.
Yeah. So,
opposite things coming out of these two federal agencies.
Right. Yeah, it's almost like they don't talk or something.
Yeah. So what kind of comments is this generating there, Jennifer? Or you yourself? You have an opinion.
Oh, absolutely. Let's see, for comments, we have one actually that says, it was from Laura, and she said she had to go in for a secondary scan one time when she was in her 30s,
Let's see that.
but never had to have it repeated, which is a good thing. What would you like me to do?
So we can all share in reading her.
Oh, you got to click on it over there.
It's waiting. It says waiting for chat.
Oh.
Okay.
Anyway.
She said what again?
She had a secondary scan at one point in her life, but never had it since. Yeah, they saw something. They followed up on it, and it was nothing.
Oh.
Or must have been nothing, because since then you've not needed any further.
So there's we do a lot of things like that where we're rechecking and following up. And
yeah.
oftentimes it's nothing. A decision has to be made. When are you going after these things and when are you not?
Right.
In everything we do, or how often you're repeating it, how often we're getting that follow-up test for something that showed up that we don't 100% know what it was. Looks like it's not, doesn't have typical characteristics of a cancer. And I go over this with patients when we get test results. I will tell them, you had something show up. It didn't have magic words in it. Magic words, speculated, concerning, concerning for malignancy. Can you think of some other magic words that radiologists use?
No, those are about it.
Okay.
If there's a lymph node, obviously.
So there's some language they use when they're reading their X-ray, mammogram, CAT scan, and reread it. And so I'll talk to the patients differently depending on what I got from the radiologist. And so if it just says, just needs to be followed up, please don't call a prayer chain over this one. This is just, well, you can.
You can.
This is just a routine recheck. And then there's other things where it, speculated nodules in anywhere.
Sure, the prayer chain, if they're going to lay on hands, that there's consent.
If there's, I will tell the patient, this is concerning. The concern is it could be a cancer. It has features that could be. I will, when I counsel a patient, but if I just have somebody else give the call, then it's...
The radiologist, they make those recommendations.
We should check,
repeat in 6 months, repeat in a year.
We do a lot of those.
Usually 6 months is when, if they see something concerning, so... Yeah, we have those discussions. We follow those USPSTF guidelines. We recommend every 2 years in a woman of average risk.
Yeah.
If you have higher risk, then absolutely. Let's have that discussion.
Please let us know.
And actually, if you look at some other bodies, if you are of higher risk, like a first-degree relative, you should be probably having that every year, that mammogram. That's different. Once your risk changes, you're no longer in that quote-unquote average risk where it's every 2 years. And we can discuss that. Dense breast tissue, not quite. It's not in that category at this point.
Yeah, the FDA statement implied that there's a higher risk for cancer with the dense breast. I could not confirm that on my literature search.
And according to the USPSTF and the literature search and review that they've done, they grade it an I, that there is insufficient data to make that recommendation.
Yeah, so it kind of makes you wonder.
Which is the body I trust.
Why did the FDA do this?
It's
actually, what they're doing is not, I talk about it as if it's something new. This is something that actually more than half of states already have in place at the state level. They're just doing it all across the entire country at the FDA level now. So in California, it doesn't change anything. We already have a law about that. We've gone over, we've had shows on this very topic before, but now it's at the national level.
Yeah. So, more comments.
Yeah.
We've got one more. Just says, I think we all are. Color me confused as to the recommendations of the government agencies.
Color us confused too.
Yeah.
We'll be there too.
We're all feeling pretty confused.
But this is something that you should have a discussion with your primary care doctor about. I'm sure they are aware and they have their guidelines that they follow. And most of us, it's the USPSTF. I see one more recommendation one more comment on there. Judy Luce, I don't know if
is that who this is?
No, this is Robert. He was the one who was confused, Robert Antonio.
So we're with you on that one.
Is that up there yet? Yeah.
Select.
There we go.
Sorry about that.
There we go.
There we go.
Yeah. Mine stated asymmetry. Not unusual.
Oh, yeah.
Yeah. Twins are usually fraternal, not identical when it comes to breasts.
Okay.
I
get it.
I like that.
Yeah. Yeah. Okay. Yeah. Symmetrical breasts.
That's not.
There may be some out there, but don't expect that you're going to have that. Yeah. Yeah. And they make clothing items as if they're all.
Yeah.
This is
Yeah.
That could go for socks and shoes too.
Sure.
It could.
Yeah. Okay.
So.
That was the last.
That was it?
Let's see. Looks like we might have gotten.
Okay.
Nope, that was it.
Okay. Yeah, just go ahead and unclick that to comment there so we.
So thank you for your comments. Appreciate it.
Yes. I had to get this off my chest.
See what you did there.
Yeah. Because I found the FDA statement to be a letdown.
Yeah.
The cursor is
Yeah.
not here.
So
Oh, it's
it's probably on our screen over here. I can just make it go like that. There we go.
There we go.
So we do need to thank Lindsay Antwine. Thank you, Lindsay, for fueling our show. Thank you, Jennifer, for helping out on the technical end and
Absolutely.
reading the hard-to-read slides. We appreciate that.
Not a problem.
And we will be back Mondays at 4:30 with more live medical information for you. Until next time,
I'm Dr. Wayne Vaughn.
Dr. Wayne Vaughn, Dr. Mark Vaughn, telling all of you to stay in good health.
See ya.
Doctors, thank you for another informative session. Auburn Medical Group is located in Auburn, California, USA. Thank you for participating. Please tell a friend and join us again next week.